Princeton University, very adjacent town. We also opened up a new clinic in Newtown, Pennsylvania, just across the river. But I'm here invited by Grace and Connor, as well as your school, to talk to you guys a little bit about some of the cutting edge stuff that we're doing. It's cutting edge only because, number one, it's not firmly accepted by everyone in the medical profession because it's very early on in its application. So it's not what's called standard of care. Okay, so I want to disclaim that before I go into any specifics. And I'm going to cite very specific studies that show any benefit to the treatments that we suggest.
You can actually look up like an increase the volume here.
Okay. Okay, so that's better. Okay. So we will talk about platelet-rich plasma as a non-surgical treatment for sports injury. Just to tell you a little bit about my background, I am board certified in physiatry, or physical medicine and rehabilitation. And I do sports medicine, but I also do regular rehab medicine, as well as some pain management and electrodiagnostics. The other track that you can pursue for sports medicine, of course, you probably already know, is to go the family practice route, or in these days, even internal medicine, and do a fellowship in sports medicine and do some of the things that I'm currently doing. So with that as an introduction, we'll get into the specifics of the talk. Platelet-rich plasma, as you know, many athletes suffer injuries. You name a joint, it's been injured. And what we've been using in the past as a standard of care, if somebody hurts a particular joint or ligament, you've heard of the classic steroid injection. It's been done for many years. And we do it for pain management. It modifies the swelling in the joint, and it helps the patient with pain. But, and we'll go over this in more detail, the steroid itself, with prolonged use or multiple uses, tends to weaken ligaments, tendons, and the joint structures. But because everyone does it, it's known as standard of care, and certain physicians in the field want something to regenerate the joint, not just help with the healing or help with the pain long term, but actually heal the joint and make it as new as possible without having to do surgical intervention. And we'll go over certain examples, and I'll show you things that we do here at the clinic, or in Lawrenceville rather, at the clinic. This is a microscopic view of platelets, and when a joint, ligament, or tendon or endothelial tissue gets damaged, platelets transform their cell bodies into these tentacle-like structures so that they can clump together and provide a scaffold for healing to start forming, including blood clots. Okay? And this is a schematic of what I mean by that. And for those of you who have taken cell histology or pathology, you are familiar with some of these terms, but if you have an injured tissue, in this picture, the basement membrane right here with the collagen is identified. What happens then is injured tissue tend to express von Willebrand factor, and as you can see there in this schematic here. What that does is it signals to the rest of the immune system that there is damaged tissue elsewhere or in that specific site. And as you can see here, the receptor GP1B or CD42 tends to bind this von Willebrand factor to recruit any number of platelets and activates it. So there's a signal transduction mechanism that then activates the thrombocyte and changes its cytoplasmic structure to have these tentacle-like arrangements that you saw in the previous slide. What that does, it also elaborates different other receptors called GP2B and A, and that in turn recruits other thrombocytes and activates them. So you have this tight network of thrombocytes really localizing to the injury, and we're trying to take advantage of this in a very useful way because we're going to target our injections to the site of injury, and we do that with ultrasound, and we'll show examples of that. So you have what you know as a blood clot because it'll tend to trap RBCs in the area and form this tight scaffold. And so once this meshwork is formed, as the slide shows, it tends to attract different types of cells known as stem cells, and they're all over the body, including tissue, and they're ready to be recruited when there is an injury. So there are signals that are transmitted locally to recruit these stem cells. And as you know, stem cells are progenitor cells, and they become specialized cells with the right signal and with the right environment. There are other things that we found in the literature, as well as in vitro studies with animals and even humans, but we believe hepatocyte growth factors are very important, vascular endothelial growth factors. And what these growth factors ultimately do, or help do, is the increased blood supply to the area because they stimulate more blood cell or blood vessel formation. So because of that, it supplies more blood supply to the injured area and hence more healing. So it's a very dynamic process, but it builds on itself as a system. So we know this directly too, is if you were to inject growth factors directly to joints or the site of injury, it can promote healing, whether you look at animal studies and even some case studies. So the question is can injecting platelets help repair, but do so to shorten the time of repair? That's number one. And number two, can we get our athletes back to play at a high level? Because performance, it's one thing to function well, such as walk or jog, but our athletes want to perform at their high level and break all sorts of records, right? So we want to see or build on this concept and apply that to these athletes. The procedure is very simple. I have staff that draw blood, 2 teaspoons of which are drawn and put in a test tube. The test tube is then placed into a centrifuge to filter out the platelets. Now it's actually been quantified. You need about a minimum of 1.5 million platelets to generate the type of healing we're talking about. So if you take into account the concentrations that are in the body at any given time, that's anywhere from 3, 5, maybe 8 times the concentration at a local site that we are treating. We filter it from the rest of the plasma, so you can actually separate the blood in what's called platelet-poor plasma and platelet-rich plasma, as well as the RBCs and whatever leukocytes are in the system. So what we do then is I draw a syringe that has full of the platelet-rich plasma, and that's what we're going to inject into the patient. Now, in terms of clinical trials, I have to mention, like I said, it's not standard of care. It's experimental, and for the most part, insurance companies do not pay for it. And patients know this coming in before seeing me. But the clinical trials are still limited. They're limited by their design because they haven't been adequately blinded, or if they were randomized and controlled for, the samples are very small. So most of the things that you will see are actually case series, so multiple patients, sometimes retrospective studies or prospective studies. But more studies, of course, need to be done. That's what every paper says. If you guys really want to look at the most comprehensive review to date from the science to the clinical application of PRP, I cite this study in the PMNR journal. Actually, this is, actually I didn't cite it here, but it's called Applications of Platelet-Rich Plasma